afternoon. Habari za mchana. Tunaomba radhi kwa kuchelewa kuanza. We are late by almost 10 minutes. But we had to transition between the two sessions. Hopefully we'll be able to catch up with time. And I want to welcome all of you here for this particular session, which is very exciting. I'm sure all of us So as we all know, we have three initiatives that we are presenting this afternoon together. So if you look into your program book, page 37, that's where the session is, which is on SBBC, Nest 360, and the Touch Health Combined Approach. So we are calling this combined approach. We have very exciting presenters on the three projects that will share with us the actual architect of the projects, what they do, and how they work together, and what problems they do address. So your moderator this afternoon is me, Dunstan Bishanga. I work with Ifakala Health Institute, but also I've been part of the SBBC team from the design to the execution. Now working with the Ifakala Health Institute also, I know what Nest 360 is doing, and I'm also educated a bit about Touch Health or Total Care. So to start, I'll have to introduce my panelists, all of them, before we start, so that when we start, we don't need to introduce them again. So I'll start with those who will be speaking, and then later I will call upon the representative of the Ministry of Health. The first speaker among the panelists will be Dr. Benjamin Kamala. If I call your name, you can proceed on the stage. Yes. So Dr. Benjamin Kamala is a research scientist working with the IDOM, who has got more than 15 years of research. He has a PhD in global health from the University of Stavanger, and he also serves as the adjunct senior lecturer at Mumbiri University of Health and Allied Sciences. The second one will be Dr. Honorati Masanja, the Chief Executive Director of Ifakala Health Institute. Jamani, hata makofi kidogo. He has focused on studies on malaria, nutrition, and the measurement of mortality and the causes of death. So he is the country lead for the Nest 360 program, and the principal investigator of several other studies. And then we have Professor Nahia Salim, Karibu, a professor of pediatrics and the director of research, publications, innovation at Mumbiri University of Health and Allied Sciences. And she serves as a clinical lead and a co-principal investigator for the Nest 360 Alliance. Makofi mengine tena. Huyo naye ni bosi wangu. And then we have Wilson Kitinya, Dr. Wilson Kitinya, who is a director of clinical services at Touch Health, a medical doctor with advanced training in clinical education, and he has co-authored several papers in areas of most public health importance. And most importantly, Asante Makofi, we have Sister Adriana William. I call her sister because she has two sister titles. The first sister from her congruency as a Catholic nun, but then she's also a sister as a nurse. So Sister Adriana is the head of nursing at Sengelema District Hospital with a Bachelor of Science in Nursing. And we have Professor Florence Kalabam, who is a consultant pediatrician and child health specialist working at Kailuki University. And he is currently providing mentorship of the Medical and Nursing Students Alliance in the prevention of neonatal deaths and through neonatal resuscitation training at Kailuki University. He's also a PhD candidate. Maria Mgoa, Sister Maria Mgoa. Boss, karibu. So Sister Maria is a district reproductive and child health coordinator at Sengerema DC with an advanced diploma in public health in nursing. So she provides leadership in maternity care and mentorship has transformed positive outcomes towards maternal and child survival. So you can see we have a very rich panel. Now, before we start hearing from the panels, we have invited the government. The first presenter, not part of the panels, but just to introduce the subject, will be Dr. Felix Bundala, the Assistant Director for Newborn, Child and Adolescent Health. So Dr. Bundala has worked for the Ministry of Health for more than 18 years, serving in the post in child care, as well as experience in policy and the guidelines development. And Dr. Bundala has, of course, published a number of peer-reviewed journals. He's a scientist, and I also understand he's also a PhD student. So Dr. Bundala, nafikiri utaproceed moja kwa moja kwenda kufanya presentation. Sijajua nani iko wapi? Hatari, eh? Unaongea tu. Basi Dr. Bundala anasema yeye anaongea tu. Sawa, karibu. Is that the way you are comfortable kuongea? Upande panda tu hapa.
Yes, good afternoon to everybody. Yeah, thank you very much, and I'm very much delighted to stand in front of this strong panel where it is mixed up. My colleague, PhD candidate, but also our supervisors who are here. Yes, when I was asked to speak a few words in 5 minutes, I asked myself, what am I going to present? Should I just say, we know you, or I should continue? But he said, as you have all evidences on the safer birth bundle, NEST, and our total care, maybe I just touch based on the philosophy part of which, and I'll conclude by saying what we are going to do based on the evidence they are going to present. In this country, Tanzania, in every year, around 2.5 million babies are being born. And of them, around 2% may be born dead. The stillbirth, 98% of that are going to be born alive. And for that matter, the safer birth bundle focuses within the labor ward. This 2.5 million will be going to be born. So we hear what they do in terms of labor monitoring, issues of the newborn resuscitation, issues of PPH management, and the rest. We also have the time to hear the outcome part of what they have been doing for the past 4 years. But to say of all born alive babies, of which I said out of 2.5 million, if it is 9%, we say the science says 20% of them will need admissions. And the admissions is for the special care within a natal care unit for the services. And where is where we found the NEST 360 now takes part in that we need to make sure the babies who are going to be admitted within the NICU, they receive all the services required, which is management of respiratory distress, ensure of the feeding, jaundice management, and the rest. But also, after that, the science also say those who are going to be admitted, out of the all, 80% are going to be premature. So we continue admitting those newborn within the NICU. But after discharge, the science shows that especially for the babies discharged with the weight 1.2 kg or below, 80% they have the risk to die at home. So the total care now comes with intervention to see what happens after discharge. So if you see, it is a continuum of the services to save the newborns. And as we all know that by 2030, what we need is to make sure that neonatal mortality goes down to 12 per thousand live birth or below that. Maternal mortality to 70 or below that, and the stillbirth to less than 12 per thousand live birth. So if we want to achieve that, we need now to make sure that we combine all this intervention, of which the government have started putting an integrated package. It is just last week where we have the team in Morogoro trying to see how we combine all these interventions toward what we want to do. So starting January going forward, we will be combining all these interventions which are going to be presented here to make sure all these expertise experiences we are gauging from them, we make sure that it stay within one document, the national document for implementation in different facilities. After saying that, thank you very much.
Asante sana, Dr. Bundala, and I think those remarks could finish this session because it summarizes everything already. But again, because we prepared, we will have to deliver what we had prepared. So now let's see, as Dr. Bundala introduced, we have 3 initiatives. The SBBC, the Nest 360, and the Watoto Care, and Attach Health. And all these, they make the combine. Now, let us start the journey to learn about this story of the combine. And at the end of the day, there will be an exam for everyone. So be careful. So, Dr. Benjamin Kamala. Okay. Professor Kalabam. So we start with the SBBC. We have 2 presenters. As I have introduced them, I want to call upon names. So after you finish, you transition. Karibu.
Thank you so much. So I'm going to present on the SBBC, and I'm going to present with Dr. Kamala. I'm going to take you through the introduction of SBBC, how it was implemented, and then Dr. Kamala will take you through the outcomes after implementation of the bundle. Therefore, as we have said before, that the bundle, as the name it is the combination of interventions, but they are done at the same time to make sure that we have the best outcomes. So in the safer based bundle of care, we had 4 components. And the first component is the training tools, whereby we have training tools to enable healthcare providers have enough skills to help those mothers who are going to deliver and make sure that they have newborns who are well before they are being discharged. So the training component comprised of the training tools such as the Mama Bethy. This is the simulation of a mother who is being in labor to make sure that the healthcare providers can learn on how to help the mother and make sure that they manage the labor way so that the mother can be able to produce a baby who is well. But also we have the neonatal alive. This is the newborn simulator, which simulates the real newborn in such a way that when the care providers are learning on how to ventilate the baby, how to help the baby breathe, they also get feedback from this neonatal alive, which is connected to the screen. So the screen provides the feedback on their performance, the frequency, the timing, the pressure of ventilations, so that they can learn how to improve on these things. But also we have the clinical tools. These are the tools which usually help the healthcare providers to monitor labor. And this, we have the moyo. This is just a strap strapped on the abdomen of the mother, pregnant mother who is in labor, so that there is continuous monitoring of labor in terms of using the fetoscope. So even if let's say the mother the healthcare provider is having a lot of patients in the labor ward, still she or he will be able to monitor these mothers, because every mother has a moyo, and also if there is any danger, then the mother will be able to tell the healthcare provider that I see there is a change of color, so that appropriate intervention can be done. But also we have the neonatal alive, the neobit. The neobit is the heart rate, the fetal heart rate measure, whereby when you put it on the chest of the baby, it is going to display the heart rates. So even if you are ventilating the baby, for example, if the child does not be able to breathe, if you put the neobit, it will be able to pick the heart rate, and then you'll be able to thank you. So you'll be able to monitor how the response is when you are doing ventilation. So because previously you used to stop and hear, or use the stethoscope to hear the heart rates and then ventilate again. But when you do that, you interfere with the ventilation, and then the achievements which you have already been made can regress. Then you have to restart again. But also we have the upright bag and mask. This replaces the one which was the angled one. Therefore, when you are ventilating, you have to be in this position. But this one has been improved in such a way that the ergonometrics of the bag has been improved in such a way that the healthcare providers can ventilate for a long time without pausing. So, and also we have the penguin sucker. This is just an instrument to make sure that you suck the circulation from the mouth or the nose of the neonate, instead of using, let's say, the long tubes also, which can make the resuscitation not successful. Next. But also we have the continuous quality improvement part of it, whereby we have to use the facility generated data to guide on what kind of training should be performed to make sure that the most common complications in the labor ward are well managed. But also, even the training data, when you are training, these training data are recorded in terms of, let's say, what are the most challenges and the like, so that you can plan for the next training, and then you build on those challenges which were met through the previous training. And therefore, the fourth component was the sustainability part of it, because we have to involve everyone. The Minister of Health, Porage, and also health care providers from those areas where the intervention was done. And then after training, we have to make sure that we train the healthcare, the facility champions, because these were the ones who are going to plan and make sure that those trainings are being done within the labor ward. And then they have to be done in the low dose, high frequency, at their own pace within the healthcare facilities. And after the training, then we have to put the learning corners within the labor ward, so that the healthcare providers at their own time can go there and learn, either in groups through scenarios, or either through individual training by practicing on how to do the bag and mask ventilation. So after that, then they were left to make sure that they can practice on those skills at their own pace. And also they can plan on what kind of training they are going to perform, depending on what are the challenges they have faced during the previous trainings. And after that, then we are followed with supportive supervision and mentorship. And this was done by the national facilitators. But also these facilitators were chosen from the regions where these interventions were taking place, to make sure that we ensure sustainability. And not, let's say, someone from the ministry goes there and then goes back. And those trainers were those who are working in the labor wards in those areas and not otherwise. Next. So the phase one comprised of 30 hospitals in 5 regions, and it aimed at attending 300,000 mother and child pair. And also, after that, there were some of the achievements which were gained during the first 3 years of intervention. And that's why it led to the scaling up of the intervention into other 142 facilities. Next. But also through this intervention, we have been able to train around 10 PhD students, and 7 from Tanzania, and then 3 from Norway in Stavanger. So I benefit to be one of the PhD fellows. So after that, then Dr. Kamara will take you through the achievements and also the next plan for the SBBC.
Asante sana, Dr. Florence. So I'm
you
going
have
to take
3 minutes.
Yeah, 3 minutes. Yeah, I will do. I'm going to take you through the outcomes of the program that was implemented in the 30 hospitals for 3 years, which was published this year in February in the prestigious journal, New England Journal of Medicine, after thorough review, and these are the outcomes. Next. So we are able to see the reduction of newborn death within 24 hours by 40%. So newborn death was reduced from around 7.5 deaths per 1,000 to almost 3.5 deaths per 1,000. And that was a very big achievement. But something that surprised everyone was the reduction in maternal death. The maternal death was reduced by 75%. Don't you want to clap for that? Yeah, so the main reason for the reduction, we did some qualitative interviews, and the midwives say that initially the number one cause was PPH, and most of the midwives were not able to mend the PPH. Whenever they saw the PPH, they would panic and maybe wait for the doctor. But after team simulation training and gaining the confidence and the competence, they are able to mend the PPH while waiting for the doctors for those which are complicated cases. But we are able to see the reduction in perinatal death by 18% from around 15 to around 12.5 deaths per 1,000. So these were the achievements of this program in summary. Next. We did not see a significant reduction in certificate documentation at the beginning. You can see in that graph that in the beginning the rates were very low, but after the implementation, the rates were very high. We encourage the midwives to report the deaths that they are not reporting so that they can be able to manage those deaths. So we think after the implementation, they are able to manage it appropriately. But also this is one of the reasons that we have increased some of the intervention in the second phase, which I'm going to explain shortly. Next. So I've already spoken about this. I want to repeat. This was newborn mortality, maternal death mortality reduction. So we have now started scaling up in the second phase, where we've included some of the components, including continuum of care, KMC, but also other leading causes of maternal death, including preeclampsia, eclampsia, and prolonged and obstructed labor. But because we are not able to reduce the stillbirth, we have also included the vacuum-assisted births training, because some of these newborns were not delivered timely. So we wanted them to be delivered timely instead of waiting for C-section, then they can be delivered by vacuum extraction. Next. So next steps, locally we are scaled up in 142, but also we are combining these bundles. We are bundling the bundle, SBBC plus VAB bundle, but also we are now working with the Nest 360. I think you are going to hear the presentation shortly, to be able to make this child who is not well managed during labor, but also they can be managed after 60 seconds. But also we are also want to combine with the total care so that we can have the continuum of care. Last slide. So what did we learn from the SBBC? One, local ownership was critical. Engagement of the government and all stakeholders at all levels is very important. Secondly, it's very important to have a champion at the health facility whenever you are implementing a program, so that the program can be achieved. A lot of healthcare workers collect the data for administrative purposes. We need to train healthcare workers to use their local data for local decision making, and then we are going to have more quality data in our facilities. Mentorship and supervision, but also system for equipment and maintenance is very, very important. Thank you so much.
Asante sana. That was the SBBC. Another round of applause to the duo. Now let's proceed and have Nest 360 next. So we will have time for discussion. So please put down your points if you have some questions. Karibu.
Asante. Good afternoon. So I would like first to clarify essential solutions and technologies. So every year, almost in Africa, most women deliver in health facilities. This also includes Tanzania. The data from the DHS shows that above 80% of the deliveries are happening in facilities. We've just heard the numbers from Dr. Felix, that 2.5 million children are born in Tanzania. So more than 80% of those children are born in facilities that we work or we serve. And out of the children that are born in Africa, about 1 million of them die due to preventable causes. 75% of them die due to causes that we can stop. And this is not acceptable. We cannot continue like this. So NEST comes in to try and solve that. So NEST is an alliance, an international alliance of clinical, biomedical, and public health experts from 23 leading institutions in Africa, in the US, and in Europe, in the UK, to be specific. In Africa, NEST is implemented in Tanzania, Malawi, Kenya, Nigeria, and recently Ethiopia. This is where almost half of the newborn deaths occur. This is why we have a focus in these 5 countries. Next. So NEST uses a health systems approach, which works with the multidisciplinary teams to transform care for newborns by delivering a package of life-saving technologies. But also we have been able to establish and maintain an education ecosystem that trains both clinicians but also biomedical engineers, whom we forget in most cases. We have a lot of equipment in our facilities, but there's no one to take care of them. Those are the same as babies. We need to take care of the equipment just as we take care of the babies, because the equipment also help to take care of us. NEST also inspires data-driven action and increases progress and quality newborn care. The theme of this conference is also about data. So we need to have good data to be able to deliver quality care to our children. Next. So NEST started in 2019, and in 2023, our first phase of NEST, I'm going to share with you very high-level mortality interim results. The full results will be ready next year in 2026, so we hope the next THS will be able to present the NEST results from Tanzania as well. But these are results from 65 hospitals from the 4 countries, which we have been able to have more than 500,000 newborn admissions in these hospitals. The interim results show a significant reduction for newborns that were admitted across all the 4 countries. And we have seen significant results, particularly in newborns between 1,000 grams to 1,999, and those above 2,000 grams, that is 2 kilos. Mortality across the facilities in these 4 countries varied, but we see significant reduction ranging between 14% to 54%. All countries had some of the facilities that were top or fast progressors, and especially for high impact interventions, which include CPAP, KMC, phototherapy, and preventing hypothermia. However, we had countries, within each country we had 1 or more of the facilities that showed an increase in mortality. And of course, this was due to very many factors, including very small spaces for caring for newborns. But of course, we've heard in the last, even previous discussions, fewer healthcare workers to take care of the babies. But of course, power outages. This is a big issue. This equipment needs power. And if there's no power, then it means you're shutting down the lives of these babies. So NEST, to address some of these challenges, especially to do with space, NEST has launched an infrastructure fund to support hospitals in upgrading their newborn units. And we have done that in the facilities that we are operating in Tanzania. Here in Dar es Salaam, all the tertiary hospitals have been upgraded in one way or the other. For instance, Temeke initially was only admitting 18 babies. Now Temeke can admit 72 babies. So this funding is trying to address those infrastructural challenges. And even currently at Amana Hospital, they have a newborn and maternal wing. We have added another ward on top, because there are a lot of babies that need care. And a lot of babies are being born. Next. No, go back. Go back. Back. Okay, twende mbele. Okay, so NEST has developed a newborn toolkit, which is free and accessible to everyone. And this toolkit is multilingual. It provides information on the newborn care that NEST, as the packages I've said earlier, it's a 360, it's wholesome, and therefore people can make references. There is a QR code that you can scan there and access the materials. Next. I think this is my last slide, which of course shows that NEST is a holistic approach where you have both technicians but also clinicians to be able to deliver care. Asanteni sana.
So that's it for NEST, right? Thank you for saving us time. Perfect. So let's hear from the Watoto Care now. Dr. Wilson.
Thank you. I hope it's good morning or good afternoon. Well, thank you. So Watoto Care comes in as introduced. We'll see. First, as you can see, is the why. Dr. Abdallah has spoken all, the death. But WHO recommends 4 critical postnatal visits, and if 90% of all babies achieve those 4 visits, then we can see a reduction of mortality between 10 to 27%. So that is the why Watoto Care. It's just to keep babies connected to the health system. Then we go to the next slide, to the how, okay, so before the next. Yeah, next, please. Okay. So here, this is showing the continuum of care. We have already seen how the other interventions, like a mama bringing in patients, especially this particular in Sengerema, and we've seen already the safer nest, and now Watoto Care gives you what happens post-discharge. And Watoto Care has currently enrolled more than 4,500 babies. Next. And a total of 2,400 teleconsultation. We'll see how. Now let's see the how. So Watoto Care is a technology-enabled system which ensures the newborn is connected to the health system. How is that done? So upon discharge, either through NICU, the nest, or maternity ward or the postnatal ward, then the baby is enrolled, the mother rather is enrolled after achieving the eligibility criteria, which are residing within Sengerema and having a phone, either by the mother herself or a relative or a neighbor. Then they sign a consent, and then they're enrolled. And depending on the condition of the baby will be either categorized as the high risk, medium risk, or low risk. And this has been put there with sustainability, cost-effective thinking in mind going forward. Some services maybe will be only for few who really need it, and others the general services. Upon discharge, if you're high risk, a community driver, formerly enrolled by a mama, will take you from the hospital back to home so that they know where you are residing. Then the following postnatal visits, you'll be picked from home back to the hospital. If you're medium risk, your data will be captured, and then the next follow-up visit, a community driver or a community health worker will visit your home and connect the mother with the clinician at the hospital, and they will talk. And then if you are low risk, you get the post-discharge information, and you are followed up at day 28 and day 42. So regardless of the risk, all mothers will get a pre-discharge information or education on how to take care of the baby, danger signs, and the importance of postnatal visits. Also, regardless of the risk category, all mothers will get a call between day 26 and day 32, that is around day 28, to ask about the health welfare of the baby and the mother, and if some key health behaviors were performed by this family. Then again, regardless of the category, at around day 42, you'll get another call, and all this information is stored. Next. So that is the how. So some of the initial results that we are seeing is Watoto Care is helping to close the gap of postnatal follow-up. Next. So in this initial 12 months of the pilot, we have seen a doubling of the postnatal visits when we compare with the baseline cohort and the intervention. So you can see how that has increased. Next. Also, we have seen that more mothers are receiving education materials. You can see initially there were very few, and now almost all of them before discharge they're getting this. And one of the results what we are seeing is that at around day 28, these mothers can recall at least 3 danger signs of the baby, which was not there during the baseline. Next slide. Also, we are seeing neonatal readmission within the first 28 days is reducing. And when we saw this, we wanted to understand more. So we have now introduced some qualitative aspect of trying to understand what are the reasons and what is happening, or what are the causes of this readmission. Next. Also, Watoto Care is providing a window of the neonatal health into the community, what is happening, especially when it comes to community death. As we know, like, currently the health system is not picking most of these community deaths because most of them, they happen before the baby traditionally connected to the service. But with Watoto Care, if during the outcome calls we find that there's a death, it's recorded, but we will go further trying to find out more reasons where the verbal autopsy is also conducted. So Watoto Care is helping to open the window into community death, of which currently the health system is yet to pick. Next. So after seeing these good results, promising results, as presented by my colleagues from the combined approach, we are also thinking of the next steps. where now the pilot has shown good results. Now we are thinking of the transition to scale, of expanding and looking at how can watoto care be implemented at a regional level with several, where also different geographies to learn more, because in one geography or the other there might be different. But also in this next phase, to continue with the doing the research to understand more. As you have seen in the one of the slides, there were our partners there. There was the government, but also MUHAS and Harvard conducting the evaluation studies. So we expect also to continue with that, and also the funding. Then after the transition to scale, we are thinking of the of going nationwide, as presented by my colleagues. Having said that, thank you for listening.
Thank you so much, Dr. Ktinya, for being on time. And you remind me that you are a teacher. You know, I was wondering whether this is a presentation or a lecture. So I think we as students will learn a big deal from your presentation. So now that we have heard from the three implementers of the three initiatives, we really want to know what happens from the point of action, from the service delivery point, where all these actors are working. What is the experience from that? And to give that experience, no other than our very best matron from Sengerema Hospital, Sister Adriana, utatueleza hivi vitu ambavyo mapicha ambayo wametuwekea hapa yana translate vipi kwa maisha ya mtoto na mama. Maana unajua unaweza kuweka slide, lakini je, yule mama na mtoto ambaye anapata hizi huduma inamaanisha nini? So you sister, kazi yake kila siku ni kufanya kazi na hao watoto wachanga na mama wajawazito wanaojifungua. Hii michoro ya kwenye maslide kule inasaidia nini? Feel free, you can speak in English, Kiswahili and Kiswanglish. Okay? Ila Kisukuma hapana. Maana watakuwepo wachache tu hapa wakina Dr. Masanja ndio wanaweza kuelewa. Sisi wengine karibu.
Good afternoon, everyone. I'm Sister Adriana. As I have been introduced, hospital matron in Sengerema. Karibu Sengerema, karibu mnisikilize kidogo. Kama alivyoeleza, mimi ni msimamizi wa watoa huduma katika kitengo cha mama na mtoto kwa muda wa miaka mingi. Lakini Sengerema ni hospitali ambayo tumepata bahati ya hawa presenters kuanzia hapo project yetu. Na huko nyuma tulikuwa pilot ya mama, lakini sasa hivi mama imecross Tanzania nzima. Tunajivunia kwa kuwa na watu. Wameeleza mengi, sitapoteza muda wenu sana, lakini kwa machache au mengi tunayoyaona kama sisi wanufaika wa hii miradi inayoendelea na research zinazofanyika ambazo zikianzia kwetu zikafanyika zikatoa matokeo mazuri, zitasambaa mpaka zifike huko kwenu. Kama mlivyoona au SBBC wametuwezesha sasa ni miaka 4. Tuna moyo ambayo moyo kazi yake ni kumonitor fetal heart rate za mama. Kama mnavyojua, nisijue huko vituoni mnakotokea, tuna shortage ya staff. Sijui kwenu mna watumishi wa kutosha. Kwa hiyo sisi Nasiro ni changamoto ambayo tunayo, tuna watumishi wachache, lakini kwa kutumia hivi vifaa moyo kwa kumonitor fetal heart rate, neobit kwa ajili ya kumonitor mapigo ya mama, tunasaidika. Tuna watumishi wachache, tuna delivery nyingi. Kituo chetu kwa mwezi tuna delivery between 350 mpaka 450. Lakini kwa duty moja tunakuwa na wauguzi 3 na au 2 na daktari 1 na specialist 1. Mnaweza mkapima wingi wa kazi na umakini unaoweza kufanyika au usifanyike. Lakini tunawashukuru hawa wa SBBC ambao wametuwezesha katika hilo. Kuna sehemu pia ya practice. Kama mnavyojua, inawezekana hujaona condition fulani kwa muda mrefu. Usipoona, usipofanya, unasahau. Lakini tuna learning corner ambayo tumeisimamia kwa umakini sana. Kila provider, daktari au muuguzi anapata muda wa kwenda kwenye learning corner na kuweza kupractice, ambayo pia hiyo imetusaidia katika kupambana na emergency sana. Lakini pia hao SBBC wanaendelea kutuwezesha kwenye mambo ya practice kama nilivyosema kwenye learning corner. Lakini pia tuna weekly and data discussion within the hospital, ambapo tunatumia data zetu kuangalia, je, tulichokifanya wiki hii au mwezi huu tumeweza kutoa matokeo mazuri. Pale tunapokuwa changamoto hazikosi, tunarudi tunaanza kujiuliza sababu ni nini, tunasonga mbele. Lakini kama mlivyosikia presenter hapa baba yangu kutoka Nest, tumepata vifaa vingi kama alivyotaja, labda wengine inawezekana mjawahi kuviona au kuvisikia. Lakini sisi Sengerema pale tuna NICU ni ya zamani, ina zaidi ya miaka 36, lakini kwa sasa tuna vifaa au vifaa saidizi kwa ajili ya kumsaidia huyo mtoto aliyezaliwa akapata changamoto akakimbizwa NICU. Kwa hiyo pale tuna vifaa vya kutosha, tumeweza kununuliwa na watu wa Nest. Wanachokiongea ni ukweli, sio presentation tu, ni actual. Pia hao Nest wametuwezesha au wamewezesha watumishi wanaofanya kazi labor ward, theater na NICU yenyewe kupata mafunzo. Lakini kizuri zaidi ambacho nadhani kwenye vituo vyetu tulikuwa tunakimisi muda mrefu ni kuwawezesha mabiomedical. Tulikuwa na mabiomedical lakini hawaonekani kwenye huduma zetu. Walivyokuja hawa Nest wamewapa mafunzo, wameweza kujua namna ya kuvihudumia hivyo vifaa kusudi mtoto anapopelekwa NICU aweze kuhudumiwa ipasavyo, na hii imetusaidia na wenyewe sasa hivi wanajifiri part of the team. Ukimtafuta biomedical anapatikana kwa sasa. Basi mtoto amekaa NICU ameshasaidiwa. Nadhani hapa kwa ni mara yenu ya kwanza kusikia watoto care. Ni kweli si kweli? Watoto care sasa yeye amekuja na hiyo initiative. Huyu mtoto tumeshamhudumia labor ward, amepata changamoto, tumpeleka NICU, amesaidiwa, amepata nafuu, ameruhusiwa. Hivi kweli huwa tunajua wanaendeleaje huko majumbani? Kusema ukweli ni hapana. Kwa hiyo baada ya hawa watoto care kuanza hiyo research yao na tukaanza kuimplement nao, kwa kweli tunaanza kuona matokeo. Research haijaisha, lakini kama alivyoeleza tunaanza kuona matokeo. Huyu mama au mtoto wanaporuhusiwa, cha kwanza wanakutana na daktari ambaye amewezeshwa kwa ajili ya kumpa elimu ya danger sign atakazoziona kule akashtuka, au akapiga simu kuomba msaada akafatwa na kurudishwa kituoni. Wanafanya hivyo na tunaona matokeo yanaanza kutokea. Kwenye postnatal visit zimeanza kuongezeka. Lakini pia kama alivyosema kuhusiana na danger sign, wamama wameanza kuelewa na wameanza kukumbuka. Na wanakumbuka siku zao za kurudi sababu wanatumiwa ujumbe. Kwa hiyo tunapoendelea tukiweza kuiadapt hii itasaidia. Kwa sababu kama mnavyojua wamama wana shughuli nyingi. Wakati mwingine hakumbuki kurudi, wakati mwingine hajui maana yake, lakini kwa kutokana na hiki kinachoendelea kwa watoto care tunaanza kuyaona matokeo, na itakapoendelea kufika huko kwenu nadhani na nyie mtakuwa mashuhuda wa sisi tunachokiona pia. Kwa kujumuisha SBBC, Nest and watoto care kidogo, kwa kutokana na data zetu tunaweza kusema kwamba at least sisi kwa upande wa hospitali yetu DDH, kama nilivyowaambia, tuna vizazi vingi. Kwa sasa hivi tukikompea na miaka 5 iliyopita tumeweza kupunguza maternal deaths kama 87%. Hospitali, sio wilaya nzima, hospitali tu, kwa kutumia data zetu za ndani. Lakini pia kwa vifo vya watoto wachanga na vyenyewe bado ni changamoto kidogo, lakini at least kama tukiangalia data tulizonazo kwa wale watoto waliofika na kusaidiwa tumedecrease about 61%. Basi kwa hayo machache naweza kusema hivi: the combined approach initiative have enhanced the capacity of healthcare provider to deliver quality newborn care, leading to improve the outcome for a newborn in the facility. Thank you.
Hello. Nafikiri makofi hayatoshi kwa sister, eh? So I'll take a minute to explain to those people coming from the Skumaland who did not understand Kiswahili. So this matron is coming from the Sengerema District Hospital, which is a designated hospital. Now we have a district hospital. But what she said, in summary, they were lucky as one of the facilities that they have implemented all 3 interventions. They started with SBBC, which did a big deal in improving the quality of services in labor and delivery particularly. And one of the things she highlighted was the fact that the innovative tools, she cited in the MOYO, was very useful in improving the quality of services because of the workload. They have fewer staff, they have a lot of deliveries, they have 350 to 450 per month deliveries, and every shift you have 2 to 3 people to attend all those women. In a day you could deliver more than 10 to 20 women. So with the MOYO, they were able to monitor the labor with the fewer staff, which improved the quality of services. But then they also instituted the culture of continuous learning with the learning corners, which was equipped for them to practice on some layer skills or layer conditions that they don't see regularly, to make sure that they remain competent in case there is an emergency that requires the skills they received. And another new shift into their practice was the use of data. They do weekly data review meetings where they look at the challenges and they use that to plan for training as well as improve the services. And as they were thinking, now we have improved the care of the mother during labor, and we have a newborn where they also do some immediate newborn care, but they did not have much capacity to take care of the newborn for those sick and small newborns. Then Nest 360 stepped in, gave them very modern equipment, which they appreciate, but also trained biomedical engineers to make sure that the equipment are being maintained. At the same time, build the capacity of the healthcare workers to provide all the required competencies. But then the care remained within the facility. When they had discharged a patient or a mother, they did not make a follow-up to what happened at the community level. Now the Watoto Care comes in with a complementary package where they have enhanced pre-discharge counseling of the mothers on identifying the danger signs for newborns, but then even making follow-up through telehealth, as well as physical visits to these newborns, where they have seen increased postnatal care visit. As she was speaking about this, reminded me of the study we did. We published a paper in 2019, I think, or 2018. We had done a study in health facilities in Tanzania, and about half of women that had delivered in the facility did not receive postnatal care, did not receive the first postnatal care, despite that they are delivered in the facility. So it seems the Watoto Care, as it comes in, it is giving that niche of improving the immediate postnatal care as well as pre-discharge counseling. Now, the big story on the news, kama kuna waandishi wa habari, kichwa cha habari, ni kwamba with all these combined, within the facility-based data, they have been able to see 87% reduction in maternal deaths, and they have seen 61% reduction in newborn deaths. Jamani, tuwapigie makofi. Now, with that story, we'd like to hear now the health manager representing health managers in Sengerema, the DRSH Corps, to tell us what does this mean in their own constituency of Sengerema in the district. When you hear a story like this from one of the facilities, does this apply to the rest of the health facilities in that particular area? Karibu, sister.
Okay, good afternoon, ladies and gentlemen. Thank you, moderator, for this opportunity. My name is Mary Mgoa. I'm a district reproductive and child health coordinator. I have to share the experience we had from the 3 combined approach. To start with, we appreciate the effort of the government, Ministry of Health, Pure Raj, RHMT, and District Authority. We appreciate the partnership we had, and we feel so proud of it. Being having of those 3 approaches makes to reduce maternal deaths, in particular to that specific hospital, Sengerema District Designated Hospital. Yeah, we were fully engaged in all aspects of planning from the beginning and also in implementation. We were invited and involved in participating, designing the Watoto Care program. And we are the key actor on how to oversee how the program is being implemented. And being so, we are also involved in mentorship. We do preparation on how mentorship will be, who is in need to be capacitated, and also we have joint supervision in collaboration of RHMT, CHMT, and implementing partners. Having doing so, we see there is so much improvement in care deliveries. Apart from that, we also observed the achievement. The great achievement with that project is, from 2024, we had a number of 20 maternal deaths, and almost 99% happens at Sengerema Designated District Hospital. But at time I'm speaking now, they have only 4 maternal deaths which occurred in January, March. From April to now, it is almost 6 months past. No maternal deaths have been occurred. So you can see how much their contribution leads to a positive and significant change toward outcome of maternal and newborn survival. Apart from that, we also have an evidence of data use. Before it was a challenge, but health workers were really trained to collect data and make discussion their own in the respective facility. And later on, they are being discussed at the district and the regional level. And this makes possible to have a plan which is evidence-based for decision making. That is the great impact we see, and we have to sustain. Without data, it is nothing. Your plan, it is unrealistic, but if you have evidence-based plan, is where we go up. And you have a root cause analysis of why do we have maternal deaths, and perinatal deaths. So you cut the grassroots of how we can also sustain, even if our partners are going to end up, we are able also to sustain. We are planning through TCHP, which is coming soon, October, from this month to December. We are going to plan, and you are invited to plan with us to chip in the activities which is beyond of your scope will be integrated into our CCHP to make it sustainable. So, having said that, according to the time, I would like also to invite partners. As I can see, the outsiders of the country or within the country to invest in Sengerema. We are really having strong leadership and committed leaders from the government, the region, and the district authority. We are capable to give you support needed to accomplish your goal. You can see many pilots have been conducted in Sengerema, and it was so useful. As you see, a Mama project, it is now scaled all over the country. We had also UNICEF on routine vitamin A supplementation and membendas. It was a pilot conducted in Sengerema, but it is now useful in the whole country. So we hope even if you come to pilot to our area, you will really succeed. Thank you very much.
Kiongozi tunaye hatuna? Okay, good. Nafikiri sasa hapa wale mnaopelekaga majina mnaweza mkaandika kabisa jina lake. Mimi sina uwezo wa kupenyeza, lakini najua mnaopelekaga majina kule ya uteuzi. So at the end we will have some closing remarks from P.O. Lag. So some of these things about sustainability, you know, she talked about the level of Sengerema District Council, but then we'll also come to hear from the government, central level government, on what they are telling us. Ladies and gentlemen, I think now we have heard from all our panelists. It is time for us to open it out for the floor to really be able to tell us your contribution, your thinking, but also ask any clarifying questions. I'll take some like 5 points before I can ask the panelists to respond. Karibu, we have the first lady there. Yeah, the two ladies. Afadhali na naume nimewaona. We have the two gentlemen and then we have the lady there. Karibu.
Asante. Good afternoon, everyone.
Good afternoon.
My name is Esther Jaswant. I am the founder of Ella Foundation, an NGO that is committed to inclusion, advocacy and inclusion of the deaf community. To say thank you to the panelists here in your respective organizations. But my question goes to the Touch Health, Watoto Care. Congrats on the piloting project that went very well. But my question is, how inclusive was the prenatal and postnatal care, especially for the deaf mothers?
Okay, please take note. We'll take a couple. We had the two hands this side. Yes, please.
Right, thank you. Good afternoon. My name is Mariam. I'm a pediatrician and a lactation consultant. My question, perhaps a question or a comment to all the three groups. All your interventions were bundles to improve outcomes. But one thing that was obviously glaringly lacking was interventions to optimize breastfeeding. And yet we know that the one primary intervention that can save newborn lives is optimal feeding, mainly because of the immune strength that it provides. We also know from recent studies from the Life Study Group in Dar es Salaam that there's huge gaps in optimal feeding of newborns, especially sick newborns. So I don't know if any of your interventions had a breastfeeding optimization component, and perhaps it was just not mentioned here, or if it was not there, then we need to talk about it as we leave this room. Thank you.
Asante. Asante? Yes. Please.
Thank you. Good afternoon.
Good afternoon.
I'm Dr. Nkungu from Morogoro Regional Referral Hospital. I appreciate the great work that is done by all of you. I have a question or concern about the babies that are born too soon or too small. We call them small and vulnerable newborns. Beyond the first 1,000 days of their life, what are the future plans? Do you have a plan for create a body of data? What happens to them after when they are adults? What about the risks for cardiometabolic? What are their cardiometabolic risks and things like that? Because most of the data we read are from the Western countries. What about the local? Can we build a body of data that we can refer to and then make interventions? Thank you very much.
Okay, asante. Dr. Sande.
Habari za mchana. So this is Sande Dominico, Director of Program of Thamini Wai, but also President for Agota. I'm really impressed for the presentation, and I'm a big fan of all those innovations. I just have some quick questions. The first one goes to Mary. I'm really impressed by the way you really position the Sengerema Sengerema Council as an appropriate ground for future investment in health. So my question would be, as CHMT, how much you have taken on board initiative to ensure sustainability, especially ensuring that is well captured in facility budgets, CCHPs. That will be a big lesson for other leaders who are in this forum. And then for the three presenters, I think the big question that comes out of this group is maybe we wish to learn in simple terms, what should the other partners who are coming in board, what are the key lessons that you want to share with them if they want to scale up those innovative models? And of course, for the government as well, the dream is to see all this being scaled up all over and over. So I think we'll be able to learn as well what will be the key lesson that you want to share in that perspective. Thank you.
Asante sana. So let's allow our panelists to respond to those first, and then if you still have time, we'll take more. I can start from my right, and then if you have anything that was addressed to you or you want to give comments when the mic comes to you, please help.
Okay, thank you very much, Mr. Sande. In response to our questions about sustainability, having TOT from SBBC on emergency, obstetric and newborn care, and also facility champion, those are going to sustain teaching others using learning corners with low dose, high frequency. So we are going to sustain. And apart from that, those equipment we are supplied from NEST 360. We have biomedical engineer, now we have 3. So having those biomedical engineer, we are in the position to plan in the budget to make replacement for those equipment which will be broken out. And also in sustainability and maintenance of equipment, we will plan for PPM, preventive maintenance, which is usually not done in most of the facilities, and make the equipment to break and being unuseful. And also, in part of our total care, sometimes we cannot duplicate much how the pilot is, but we imitate in part of postnatal follow-up, post-discharge. We usually use phone telecommunication as we do in those pregnant women with high risk. We make follow-up through CHWs, and we have a number of CHWs who are trained, about 105, and every village have it. So from that column, we wish will be in a place to follow those babies as we see have a great impact to see how are they develop and thrive. Thank you very much.
Thank you so much. I'm going to just have a response on the issues of breastfeeding from Dr. Noran. Yes, indeed, the SBBC one did not include those care of newborns after delivery. But after introduction of SBBC 2, we had other components, which also include, for example, kangaroo mother care, breastfeeding management, and also care of the sick and raw birth newborns. So at least we have thought about that. And another thing is on the key lessons from Dr. Sunday. As far as SBBC is concerned, we have main three, and some will be contributed by Dr. Kamara. But one of them is to make sure that whatever you are inventing or you are intervening is owned by those intended users of the intervention. So you have to make sure that all stakeholders, most important stakeholders, are on the round table to discuss and how to implement whatever you want to implement. So if they understand it, then it's likely going to succeed. For example, even the Safer Birth Band of Kaya, we have the so-called no blame, no shame culture that we are learning. A lot of mothers and newborns are dying, but we have to report those deaths so that we know, we understand what is the problem, so that we can sit and discuss how to intervene. Because previously we are thinking that some of the cases were not reported because people were a little bit scared. But after that kind of approach, everything was on the open space so that we can improve. But another thing is the evidence. People have to really understand, and they have to know that really indeed the intervention is working through the evidence. For example, for those after starting those training, and then when the maternal deaths, newborn deaths went down, people started believing that yes, indeed, this can work. So after even other publications showing how what they are doing is related to reduction of those maternal newborns, then they had more confidence and they continued to practice. Thank you.
Thank you. I'll respond to several questions. I'll start with the lady here from the Inclusion NGO on how inclusive was the care, especially the DIF. So, Watoto Care operates within the hospital system itself, and it's upon discharge, and so it follows all the protocols. But in case of any handicapped, these mothers are not alone. Normally there's a relative or the husband. So I know a few cases of such where we had to really talk to the relative or the person who accompanied the lady to be able to get the consent. But during the follow-up also, there was somebody who really helped on the communication. Regards the breastfeeding, it has already answered, but maybe to add, on the part of our total care, it's a topic that is covered during the pre-discharge education. Also, for the high risk and medium risk, during the follow-up visits, whether physical for high risk or teleconsultation, the clinician has a place to ask specifically about breastfeeding. Not only that, during the outcome calls at day 28, we also ask if the mother is doing exclusive breastfeeding. It doesn't stop there. As I said, we have the research which goes to the homes of these mothers at between 9 to 12 months. Also, breastfeeding is asked, plus what was done post the 6 months. So our research data has all that documented. To Dr. Nkung from Morogoro, thank you for a very good question. We had this question even during the design. How far can we go? Because if you look at Watoto Care, it's just a window or a starting point into early childhood. So we really had to dig a bit more about the early childhood, but also given the resources and wanting to start there. So Watoto Care pilot goes all the way to 42 days. However, we have now the research part, and thank God the PI of that research is here, not other than Dr. Martha, which now is looking, I'll say, midway to the 1,000 days, because it's between 9 months to 12 months, where now we are going to the home. We are asking questions about the welfare of the babies. And I can tell you, they recently concluded data correction. We have already seen that, especially the low APGAR score babies, they need some extra services. And we have already addressed that already with the hospital. The last time I was in Sengerema, we were already discussing how to keep them in the system and how to give them proper counseling and proper care. So the journey is there. We started, and we believe we are continuing. To Dr. Sunday, I think it was, has already addressed well, and I'm sure my colleagues here will address, but just I'll say involve key people from the start and collaboration with the other partners. I'll add that.
Thank you, everyone, and thank you for having us today. First of all, maybe I can narrate what combines mean, and I'll try to respond to all the other questions which have been tabled by sharing the learnings. I will not be responding to only Dr. Sandy, but integrating those learnings and respond to Esther, Dr. Mariam, and Dr. Nkungu's concerns. First of all, COMBINE stands for Care of Mothers and Babies, Innovation for National Equity. And that initiatives came from just few of us sitting together, discussing what we are doing in country and how can we develop a strategy or an approach which can support our nation. So thank you, Professor Joy. I recognize your presence today. And led by Professor Joy and with the support from the international collaborators, we came up with this combined approach. So it stands for Care of Mothers and Babies, Innovation for National Equity. And today, we are happy to celebrate that we did not, it did not mature and we did not receive that funding we were targeting. But the good thing is the implementing partner, the development partners, I think, heard about us and our cry. And now we have a huge investment coming into countries, and Tanzania included, called Beginning Fund. And actually, we are happy to say that today, Tanzania is starting this movement, and the Beginning Fund will support scale and sustain movements within several regions within Tanzania. covering more than 200 plus facilities within these regions. And this includes also Zanzibar. So again, congratulations to the Minister of Health and thank you for moving us towards this direction. So one learning is we should not underestimate our power. We should not underestimate whatever we contribute in our spaces, in our desk, in whatever we are doing day to day, to move our agendas we are working with, whether from a research perspective or from the clinical perspective or any other angle we are working with. One day, you will make a difference. And now, we are proudly, and I'm happy to congratulate this team that today we see that we are making a difference, and we are happy for this. So hopefully we will be working more into more regions to this approach, and we have a lot. This is a huge commitment. It's a huge work. It's not a joke, because learning just from implementing the NEST 360 program in facilities, the facilities needs to be supported. The facilities, for me, is a functional unit of whatever health investment we are putting in to see the products and the outcome. The other angles or other system is more of supporting. So we need to support the facilities to do best in terms of not only coverage, but quality. You may have a huge coverage of a certain intervention, but if you deep dive into the quality of that intervention delivered or that service delivered, this is where you see, oh, this is why we are not progressing. So the quality of care matters to progress ourselves from one point, one target to the next. But not only one intervention will work, it's several interventions as a package, as a bundle. And this is why now we are talking about combined approach. And we will continue learning in terms of innovations, which are new, which are coming and roaming in, and we need to digest how these innovations will be integrated into our system to support progressing ourselves as a nation. So coming to the learnings, I think I would like to pack them in pillars. And several learnings have been out there. Most of these are open resource. And you can access, any country can access, even us as Tanzanian can access whenever we see our facilities ready to, or the region is ready to do so. So in terms of infrastructure, we already have a costed national floor plans at the district and regional level.
Can you
where we can
Professor,
adopt.
can you summarize in 1 minute?
Yes,
Because we are
yes.
over time.
So
Sorry.
in terms of device ecosystem, we have all resources in place, including essential commodity list for the maternal and newborn, hosted at MSD. And within the human resource workforce, we have the training materials for in-service and pre-service. Some of the new courses have been, some of the curriculum have been introduced, and we're thinking of more pre-service curriculum to be introduced to support our nation. We have quality improvement and mentorship tools. We started with the generic instructor course. Now we are talking about the GIC plus, which includes the training of mentors plus the components of continuous quality improvement and mentorship in it, because we want it to be packaged from the beginning. So people and our implementers, our human resource workforce at the facility level, think of the quality process and mentorship process and capacitating the facility team and the working improvement team within the units to be able to accommodate quality improvement processes, but also in the council level and regional level to support the facility implementation. In terms of data, we do have a minimal data set to support neonatal indicators as part of our tracking towards our progress into the targets, but also learnings from the gaps. We are including maternal indicators, and now with the combined approach, we'll have a comprehensive minimal data set with variables tracking our progress from the maternal to the newborn to the postnatal follow-up to guide our Minister of Health and how best to implement.
Asante. I'll ask people to follow up.
Just before closing, we noted that breastfeeding is a problem, and I would like to say that we are working on it. We are learning from life and lived studies, And we'll have, I think this week, we have a meeting with the global team and the national team in Tanzania to see what variables can be entered to track breastfeeding, because optimization of breastfeeding is critical for these babies to survive and get them discharged, and also the part of thriving and transforming. Asante.
Asante sana. Ana nondo nyingi, sema muda hatuna. So please, 30 seconds each.
30 seconds.
Yeah.
Lessons do not reinvent the wheel. A lot of heavy lifting has already been done. Materials are available and they are free of charge. Thank you.
Perfect. Yes, Dr. Kamala.
Nilikuwa sitaki kuongea baada ya mwalimu wangu, lakini kwa sababu nipa nafasi niongee. So to me, I think a better trained, well supported and equipped healthcare worker, especially pale labor ward na newborn unit, is very critical. So tunaweza kuwa na vifaa vingi fancy, lakini kama huyu healthcare worker hatujamtarget, hatutapata. Kwa better trained, equipped and supported healthcare worker is very critical. Asante.
Perfect. Ladies and gentlemen, let us now hear from the POLAC, from the government. We have Sister Mary Karibu. Mary Shadrack is the Assistant Maternal and Child Health Coordinator from the President's Office, Regional Administration and Local Government. Karibu. Atapapo.
Thank you so much. On behalf of PORAJ, we would like to thank you all panelists and all participants who are here. So this is our comments and remarks from the SBBC, NEST 360 and Watoto Care are all in the line with the government priorities and have established remarkable intervention in primary health care, as well as promoted quality of care in maternal and newborn in Tanzania. But also these interventions are being aligned with the national health priorities through coordinated planning with the regional and local government authorities. Again, integration into council health plans, ensured sustainability and ownership at the local government, as Sengerema was said here. Data systems are being strengthened to track maternal and newborn outcome and inform local decision making as well as the government. So we have seen tools and protocols being embedded into routine service deliveries across the facilities. So in collaboration with the MOH, PORAJ and the stakeholders, we will ensure harmonized implementation and resources mobilization. This intervention need to be harmonized and scaled up to nationwide as combined approach is stronger and robust in outcome in maternal and newborn. So with these remarks, we highly encourage all partners, SBBC, NEST 360, and Watoto Care, to continue with their collaboration and be assured that PORAJ will support. Thank you.
Asante sana, makofi mengine tena kwa serikali. I just want to recognize some very important people in this room. We have the DMO for Sengerema, Dr. Darrison. If you can wave. Yupo. Dr. Jessica, the RMO. Unaona. Bosi yuko hapo. Dr. Jessica, umemsikia lakini sister hapa? Umesikia alivyotetea uwekezaji kule? Mkamfikirie. Before we take a group photo, I'm told there is an award from the organizers, Tanzania Health Summit, to one of the members. Naomba mje mtoe hiyo award alafu tupige picha ya pamoja kwa nani? Karibu.
Good afternoon to you all. Okay, the Tanzania Healthy Summit 2025 Forum Recognition Award is presented to Hydron Lutheran Hospital. photos in appreciation of your continuous commitment and leadership in strengthening healthcare system across Tanzania and beyond. Thank you.
Asante na ongeleni. Baadaye mtatuambia tunavunjia pikamati. So can we have a group photo for the panelists, please? Naomba tusogee mbele hapa tupige picha moja nzuri sana. Naomba Dr. Bundala na Sister Mary na nyie msogee mbele. Karibu. Karibu mbele ya hii nani.